The next, we will talk about hypokalemia. Hypokalemia when the extracellular potassium concentration is less than 3.5 millimole per liter. Usually, the ECG sign occurs when the potassium concentration is below 3 millimole per liter. Hypokalemia, generally talking, if the extracellular potassium concentration decreases, the excitability of the nervous system and the skeletal muscle cells decreases, so more difficult to excite these cells. However, the heart cells, the excitability will increase. The symptoms generally be the muscle weakness, muscle spasm, muscle fasciculation, paralytic ileus, hypotony, and hypoventilation, and arrhythmias. In hypokalemia, the conductivity of the conductive pathways slows down and the excitability of the cardiomyocyte cells decreases. Excitability of the nodal tissue, however, especially the Purkinje fibers, increases due to the increased phonic current leading to increased depolarization. So when the phonic current increases, these cells will reach the threshold earlier and action potential develops earlier and more frequently. Besides of this, premature ventricular contractions, tachycardias, flutter, fibrillation may also occur. So ventricular tachycardia, ventricular flutter, ventricular fibrillation can develop very easily. Ventricular repolarization is prolonged due to the inhibition of the rectification. At a certain point, the inward ion current becomes greater than the outward. This, as you see here, so the inward current be higher than the outward current, and that will cause early after depolarization. All this leads to the re-entry arrhythmias, and those are the points tachycardia, frequently associated with hypomagnesia, which predispose to the malignant ventricular arrhythmia. This is why you should check the magnesium concentration when the potassium concentration is low, because the chance that malignant arrhythmia develops is much higher. And for the treatment, we should apply both magnesium and. Talking about the ECG sign of hyperkalemia, in moderate case, we do have a flattering and inversion of the T wave, prominent U wave, ST depression, prolonged QU interval due to the disappearance of the T wave, plus a wide P wave, peaked P wave. When we do have a severe hypokalemia, the frequent ventricular and supraventricular ectopic beats occur. Atrial tachyarrhythmias, atrial flutter, fibrillation develops, and further ventricular tachyarrhythmias such as ventricular tachycardia, ventricular flutter, fibrillation, and those are the
Early
points
ECG changes in
develop.
hypokalemia are mainly due to delayed ventricular repolarization. These include flattening or inversion of T wave, increasingly prominent U wave, ST segment depression, and prolonged QU interval.
Looking at this tracing, this is rhythmic, the heartbeats are rhythmic. The rate is normal, 1, 2, 3, 4, almost 5, so 65 beats per minute. We do have sinus P wave and in front of every QRS complexes. However, we do have a PR interval, is 0.2 seconds. The QRS is not pathologically wide and the axis is normal, it's around 60 degrees. Looking at the ST pathologic Q wave, there is no pathologic Q wave, so the QRS complex otherwise is good. When we're looking at the chest leads, how the R progression occurs, that's normal. Looking at the ST segment is depressed in lead number 2, lead number 1, and AVF, V2, V3, V4, V5. And as you see here, we do not have T wave. So the T disappeared, and instead of the T, we do have another wave that is very, very far from the QRS complex and very close to the P wave. So this is the wave that is called the U wave. So if you're looking at the QU interval, is extremely elongated. The same ECG taken from the same patient, now it shows different things. First of all, on the left side, we do see that this patient does have very similar data, so the QU interval is elongated, ST segment is depressed. And additionally, however, when an R on T phenomenon, R on U phenomenon comes, that's a torsade point tachycardia was induced and the patient developed a malignant tachyarrhythmia, ventricular tachyarrhythmia.